Good morning, everyone. Today we'll discuss recent updates in transplant pathology. My part will be covering liver pathology. So I'm from hepatology. I'll be covering that. Today we are going to present a case of 21-year-old female resident of Gorakhpur. She presented to us with decompensated cirrhosis, etiology seronegative AIH, with diuretic responsive ascites, with portal hypertension, non-bleeder, with small esophageal varices with no hepatic encephalopathy, MELD score being 16, 19, and CTB being 9. Her index presentation was in September 2020, where she initially presented with prodromal symptoms for about 10 days. After that, she developed jaundice with pruritus and received symptomatic treatment from a local hospital. Thereafter, she improved. Then in December 2020, she developed gross ascites requiring LBP. At this time, she was referred to our center at SGPGI. There was no history of hematemesis, melena, bleeding PR, or altered sensorium. No history of any comorbidities or operative procedures in the past. There was no history of addiction or no similar family history. Patient was investigated extensively at our hospital. Her viral markers were negative, including all typical and atypical viral markers. And workup for Wilson was also done for the patient. That also came to be negative. Autoimmune markers were also done, which were negative, including IgG, which was within the normal limit. Her ultrasound abdomen and Doppler was done, which was suggestive of liver coarse ecotexture with irregular margin, with splenomegaly with portal hypertension. Patient was evaluated for etiology, but despite autoimmune markers being negative, there was a strong clinical suspicion that the patient has autoimmune hepatitis. So TGLB was carried out. Then on the basis of the biopsy, we had started the patient on prednisolone, as biopsy was suggestive of features of seronegative AIH. Now, ma'am.
Good morning to all. I will be present the histology part of the liver biopsy. For this case, we received liver biopsy in the form of a linear course. Here we can see there is the marked acinar disarray, which can be appreciated in reticulin stain. There is near total collapse of the reticulin fiber. In this microphotograph, we can see these are the portal tracts. The portal tracts are expanded, and there is hepatocytic necrosis. On high power view, we can see that the portal tract are expanded by marked fibrosis along with moderate mononuclear inflammation comprising of lymphocytes along with plasma cells. These are the plasma cells. These are the portal tract also showing the bile ductular proliferation, and in between the portal tract, the hepatocytes are lost, and there is the hepatocytic necrosis. Here also we can see this is the one portal tract and this is the another portal tract, and in between the portal tract there is complete loss of the hepatocyte and it's showing multi-acinar necrosis. This is the high power view, and these are the ductular profiles, and these are the adjacent hepatocyte showing the necrosis. This is another photograph, microphotograph showing the same picture. So the biopsy is, and this is the Orsin stain. And in the Orsin stain is negative in this hepatocytic necrotic area. So the diagnosis is given as acute on chronic hepatitis with extensive necrosis.
After patient was started on tablet prednisolone, the patient was followed up for a few months, but patient was non-compliant to steroids. And after 5 months, she presented with acute flare. For that, patient was admitted to hepatology ICU for further management. Let me take you through the LFT from the very start of the patient profile. When she came to us in January, her bilirubin level was 3.8 and direct was 2.4, and OTPT were 10 times 567 and 351. Alk phos was 280 and albumin was 3.5. In around Feb to March, we had done the biopsy for this patient, and after that, where you can see the arrow, prednisolone was started, and then patient gradually showed improvement. Her bilirubin came down to 2.1 and OT 238, 510, and then gradually in June it came down to 60 and 68, OT and PT. Subsequently, in August, her AGFOS also came down to 140 and bilirubin was also 2. And OTPT were 52 and 59. But then because patient was non-compliant through this month, then and subsequent months, patient presented to again with acute flare with ACLF-like presentation. And her bilirubin rose to 4.3 and 2.9. And OTPT were again 168 and 260, which subsequently there was persistent liver and coagulation failure for this patient. Due to persistent liver and coagulation failure, patient was given option of liver transplant. LT workup was started for this patient and the prospective donor being her sister. Patient underwent LDLT on 12 February 2022, where ABO incompatible B positive to B negative left lobe graft was done. After LDLT, patient LFT showed improvement and she was discharged on immunosuppressants. Now, ma'am will discuss the explant.
Then we received total hepatectomy specimen in February 2022. Grossly, the specimen measured 14.5 by 11 by 9 centimeter and weighed 757 gram. Outer surface was tan brown and capsulated. And cut surface of both the lobe and the caudate lobe, showing the multiple nodules, which were ranged from 0.3 centimeter and largest was the 1.1 centimeter. This is the microphotograph from the right lobe showing multiple nodule. This is the one nodule. The portal tracts are expanded by fibrosis with bridging fibrosis and formation of this complete nodule, which can be highlighted by reticulin stain and as well as the mesenterichrome stain. This is the section from the left lobe, which showing complete necrosis. And this is the section from the caudate lobe, again showing the nodule formation and the adjacent part showing the necrosis. Here also we can see the formation of the nodule along with some dilated ducts and the necrotic area. This is the microphotograph showing the portal tracts which are expanded and forming this bridging fibrosis. Here we can see the moderate to marked fibrosis along with this bile ductular proliferation and moderate mononuclear inflammatory infiltrate. In this also we can see these are the bile ductular proliferation, ductular metaplasia along with mononuclear inflammatory infiltrate. Minimal interface activity is noted here. These are the portal tract and these are the adjacent hepatocyte, and there is some interface activity in which lymphocytes and plasma cells are seen within the hepatocytes. And these are the other areas showing the necrosis of the hepatocyte. So the diagnosis was given as a cirrhosis with multi-acinar necrosis.
Patient was then followed up and post LTLT patient presented after 2 to 3 months. She again presented to us with complaints of pruritus and worsening of liver function test. Initially the ALP and AST were raised, and on evaluation, she was found to have urine culture positive showing E. coli, for which colistin was started. However, patient did not respond to that and her LFT and pruritus continued to rise. Then it was considered that patient might have acute cellular rejection of the graft, for which again liver biopsy was done.
So we received post-liver transplant biopsy on May 2022. The biopsy shows largely maintained lobular architecture. This is the mesenterichrome stone showing the maintained architecture. This is the portal tract containing normal bile ducts, minimal inflammatory infiltrate, and mildly dilated portal vein. And the adjacent hepatic parenchyma is largely unremarkable. This is the another portal tract showing these bile ducts, which are largely unremarkable. Inflammation is minimal, and there is some dilatation of the portal veins. This is the sinusoidal dilatation. This is the sinusoidal dilatation along with dilatation of the central vein, and the adjacent hepatocytes are largely normal. This is the high power view showing the dilatation of the central vein along with sinusoidal dilatation. So on the basis of the morphological feature, there is no evidence of any rejection. There is no bile duct injury. There is no increased in portal inflammation, and there is no endothelitis. So diagnosis was given as no evidence of rejection.
Then this was the post-LT LFT patient after LT, which was done on 22 February. Her OT and PT came down to 55 and 107. Then in March, when she was followed up, it was the bilirubin was 1.1, conjugate was 0.3, and OTPT was 31 and 41. And then since then, it was in the normal range. But around May, she showed derangement, which was 3.6 was bilirubin, 2.8 conjugate, OT was 94, and 246 was PT. At this time, her biopsy was done. Then after biopsies was suggestive of no evidence of acute rejection. Patient was again looked up for other causes. Her MRCP was done, and it showed that there was anastomotic leak and biliary dilatation. So patient was planned for ERCP stenting. Subsequently, her LFT became normal. So this was all. Thank you.